Hi everyone, and welcome to our module on antithrombotic drugs. There are a number of diseases which we call thrombus disorders, and these are conditions where thrombus forms in the body where it shouldn't be, and as a result of the thrombus formation, the patient becomes sick. And I've listed here the thrombotic disorders and the location where thrombus forms. So in atrial fibrillation, there is sluggish blood flow in the atrial chambers of the heart, and thrombus can form in the left atrial appendage of the heart, and if a piece of this breaks off, it can cause a stroke. In myocardial infarction, thrombus forms in a coronary artery. In deep vein thrombosis and pulmonary embolism, thrombus forms in one of the deep veins of the leg, usually the femoral vein, or in the pulmonary artery. In stroke, we get a thrombus in the CNS circulation, and finally, in critical limb ischemia, we get a thrombus in the peripheral circulation, usually in the legs. Antithrombotic drugs are used for acute therapy when patients have an active clot that's already formed and needs to be eliminated, but they're also used for prevention. And actually, most of the patients you're going to see on your clinical rotations will not be on antithrombotic drugs for an acute condition, but they're on them because we think their risk of forming a thrombus is so high, we are treating them with antithrombotic drugs to lower the risk. Now, in order to form a clot, you need two important ingredients. First, you need fibrin, which comes from the coagulation cascade, and second, you need activated platelets. And these two ingredients mix to form a thrombus. And we have drugs that work on both elements of the thrombus. So anticoagulants, which are sometimes also called blood thinners, are drugs like heparin, warfarin, direct thrombin inhibitors, and factor Xa inhibitors. And they all blunt the formation of the fibrin component of the thrombus. Antiplatelet drugs, on the other hand, are drugs like aspirin, ADP blockers, 2B3 inhibitors, or phosphodiesterase inhibitors, and they block the formation of activated platelets. And I discussed these in a separate module on antiplatelets. And then finally, a special class of drugs is called thrombolytics. This includes drugs like TPA, and these drugs actually directly lyse thrombus to break it down into degradation products. It's important to know that all these anticoagulants don't directly lyse a clot. They just blunt the formation of more clot. The body has a natural balance between clot formation and clot breakdown. And if you stop the clot formation with these drugs or limit the clot formation with these drugs, then the body's natural mechanisms can break down the thrombus. Thrombolytics work through a special mechanism, and we'll talk about that later, where they directly lyse the clot, but they are the only drug class that does this. For different disorders, we use different drugs, and I've listed on this slide some acute conditions and the drugs that we use, and some chronic and preventative situations in thrombus disorders and the drugs that we use. You'll notice on this slide that we mention aspirin, heparin, and warfarin quite frequently. These are time-honored drugs. They're very old drugs that are very inexpensive, and they still work quite well. Newer drugs have come on in the last few decades, but it's hard to beat the old standbys, and by and large, aspirin, heparin, and warfarin continue to be the drugs that we use most frequently. One way to keep straight which drugs are used in which disorders is to think about whether they are venous clots or arterial clots. Venous clots like deep vein thrombosis and pulmonary embolism are more often treated with antithrombotics. The clots in these disorders tend to have more fibrin than platelets, and we sometimes call them red thrombus. Arterial clots like those in MI or stroke are more often treated with antiplatelets. These blood clots have more platelets than fibrin, and we sometimes call them white thrombus, but this is just a rule of thumb and it doesn't hold up 100% of the time. Before I go any further, let me mention bleeding. Bleeding is a big problem for patients taking these drugs, and the reason is because thrombus formation is very beneficial to the body. You may not realize it, but every day we bump into things and small, tiny bleeding events occur inside our body. But because we can form thrombus, we immediately clot those blood losses off, and we don't have any bleeding complications. If you inhibit the thrombus system, you get bleeding as a major side effect, and it is a side effect of all the drugs I'm going to talk about today. When you think about it, there's a balance in the body between clotting and bleeding. Too much clotting and you get myocardial infarction, pulmonary embolism, deep vein thrombosis, or stroke, but too little clotting and you have GI bleeding and CNS bleeding and bruising. So we're trying to always work this balance for our patients. When we think they're at too much risk of thrombus formation, we'll give them blood thinners, but then we sometimes tilt the balance in the wrong direction and patients have bleeding complications. So I've drawn here for you the clotting cascade, and if you look up the clotting cascade in a textbook, you'll find that it's much more complicated than what I have drawn here. What I've done for you is boil it down to just the elements you need to know in order to understand the anticoagulant drugs. There are many more factors to this cascade, and you need to know them when you're talking about hemophilia disorders, but you don't need to know all those factors for what we're going to talk about today. So there are two pathways which can activate the clotting cascade and trigger proteins found in the blood to form fibrin and clot, which forms a thrombus. The first pathway is called the extrinsic pathway, and the second one is called the intrinsic pathway. To start the extrinsic pathway, you have to add tissue factor, and that's why it's called the extrinsic pathway, because you have to add an extrinsic factor, tissue factor. For the intrinsic pathway, all the factors you need are already present. Tissue factor is also called platelet tissue factor, and it's a protein found in the subendothelium, and it's exposed to the bloodstream when there is endothelial damage, and that triggers this coagulation cascade to form fibrin and clots and plug up the hole. Tissue factor converts factor 7 to factor 7A, and then through a series of steps, factor 7A converts 10 to 10A. 10A converts prothrombin, which is also called factor 2, to thrombin, which is factor 2A, and thrombin, through a series of steps, will form fibrin and a blood clot. So the first set of drugs we're going to talk about are all factor 10 related drugs. These include unfractionated heparin, low molecular weight heparin, fondaparinol, rivaroxaban, and apixaban, and the last two are the only two in this class that are oral drugs. The rest are all intravenous or sub-Q drugs. So heparin works by activating antithrombin 3, which is a naturally occurring protein in the blood. And antithrombin 3 will go and blunt the formation of 10A from 10. It will also blunt the formation of thrombin from prothrombin. So heparin works indirectly through antithrombin, and it activates that factor's activity. Unfractionated heparin is given as an IV drug, and it has acute onset, and it increases a blood test, which we'll talk about later, called the PTT. It has lots of binding to plasma proteins in cells, and this means there is a highly variable response from patient to patient. You have to adjust the dose based on whether or not you've achieved your goal PTT, and this drug can be reversed with an antidote called protamine. We use it in the acute management of deep vein thrombosis and pulmonary embolism, also in MI or stroke. We'll sometimes say we're going to heparinize the patient because we think they have a thrombus. It's also sometimes used as prophylaxis for deep vein thrombosis in hospitalized patients. Patients who are bedridden are at increased risk for forming DVTs from the stasis of blood, so we will sometimes administer daily subcutaneous dosages of unfractionated heparin to lower their risk. The main side effect is bleeding and also thrombocytopenia, which I'll talk about in a minute. With long-term use, you can get osteoporosis, but this never occurs in the modern era because we almost never use it long-term. And it can cause a very mild increase in AST and ALT, but this is usually not serious. So let's talk about heparin and thrombocytopenia. This is a very important and potentially dangerous side effect of the drug. For most patients who are administered heparin, they will see at most a mild drop of 10 or 20% in their platelets. So for example, if their initial platelet count was normal at 200,000, it might fall to 190,000. However, much more serious is a far greater drop called heparin-induced thrombocytopenia, or HIT. This is an immune-mediated reaction where immune complexes bind to something called platelet factor 4, and it's high yield to remember platelet factor 4. About 5 to 10 days after exposure to heparin, there'll be an abrupt fall in platelets, more than 50%. So that patient with a normal platelet count of 200,000 will see their platelets drop to 90,000 or 80,000. Now, when platelet counts are dropping, you would think it's hard to form thrombus, but in these patients, they have both arterial and venous thrombosis because of the immune reaction. So they can develop blue fingertips from blood clots traveling distally in their arms, and they can develop blood clots in the deep veins of their legs as well. Thankfully, this is very rare, only about 0.2 to 5% of heparin patients, because it can be potentially life-threatening. Patients who develop HIT have to have the heparin stopped, and they need to use alternative drugs. Usually we go to leparudin or bivalirudin, which are direct thrombin inhibitors. Now let's talk about low molecular weight heparin, which is also called enoxaparin. This is a close cousin of unfractionated heparin, but we've distilled the heparin polymers down to just the low molecular weight compounds. This works just like unfractionated heparin on antithrombin 3. However, there's one critical distinction, which is that low molecular weight heparin does not inhibit prothrombin's conversion to thrombin. It works only on factor 10 and 10A right here. That is the main difference in mechanism from unfractionated heparin. The benefit of low molecular weight heparin is that it's got more predictable effect, so you can dose based on weight with no titrating to the blood test PTT. It has reduced binding to plasma proteins in cells compared to unfractionated heparin, and we also can give this drug subcutaneously instead of IV. Couple special things to know about low molecular weight heparin. We generally don't monitor the levels. The dose is based on weight, but if you do need to monitor for any reason, you must do a special blood test called an anti-10A level. The only two times we sometimes do this are in people who are obese or who have renal failure, because both of those patient types can have variable responses to the drug. And unlike unfractionated heparin, low molecular weight heparin is not reversible. Let's talk generally about factor Xa inhibitors. Heparin and low molecular weight heparin are indirect inhibitors, and they work through antithrombin 3. And you should remember that if patients have an antithrombin deficiency, they will have a blunted response to heparin. When you give the drug, their PTT will not elevate as it should. This is called heparin resistance. And the reason for this is because heparin works through antithrombin 3. Rivaroxaban and apixaban are direct inhibitors of factor Xa, so they work without need for antithrombin 3. And about the only important side effect of these two drugs you need to know is bleeding. There are also drugs that directly inhibit the activity of thrombin, and these are called direct thrombin inhibitors. They are named things like Hiradin, Lepirudin, Bivalirudin, and Desirudin. They all end in iridin. Also argatroban and dabigatran. And it used to be that these drugs were only used in patients who had HIT, but now that we have an oral direct thrombin inhibitor, dabigatran, this is sometimes used in AFib, and I'll talk about that in a minute. So now let's talk about warfarin, a very commonly used drug that you will encounter frequently among your patients. Remember that there are 4 key vitamin K factors, and these are 2, 7, 9, and 10. And warfarin is an antagonist to vitamin K, so it will lower the levels of all vitamin K factors in the blood. It takes several days for warfarin to reach an effective dose, and we adjust the dose of the drug to reach the target PT/INR. I'll talk a little bit more about this blood test later. Warfarin's impact on the body is affected by diet and drugs. In particular, antibiotics can cause the INR to become very elevated in patients on warfarin. So you need to frequently monitor their INR level to make sure that their blood is not too thin and they're not at risk for bleeding. Warfarin crosses the placenta, so we generally don't use it in pregnancy, and its main side effect is bleeding, but there is a special side effect called skin necrosis, which I will talk about in just a minute. Warfarin's used for stroke prevention and atrial fibrillation. This is probably its most common indication. Patients who have mechanical heart valves are at risk for forming clot on the valve, and patients who have had a prior DVT or PE and are at risk for another thrombus will be placed on these drugs. So let's talk about the prothrombotic effects of warfarin. Protein C is a vitamin K dependent factor that is an anti-clotting factor, and it has a very short half-life. On this table I've shown you the half-life of several vitamin K dependent factors, and you'll see that factor 7 and protein C have very short half-lives. So when you initially administer warfarin, you make the patient protein C deficient, and you briefly induce a prothrombotic state. This is what causes skin necrosis. If you give a very high dose of warfarin, patients will become so protein C deficient that they will thrombose their skin. Now, this almost never happens in the modern era because we use very low dosages of warfarin. However, if you ever administer warfarin to a patient and they do develop skin necrosis, they most likely have a congenital protein C deficiency. They are already low in protein C, and then when you give them warfarin, that level drops so low that they develop skin necrosis. Now, we still give warfarin because the prothrombotic effect is brief. Eventually, the other clotting factors have their level fall, and the overall effect will be an antithrombotic effect. So the question that comes up clinically is, should you start another drug with rapid onset like heparin anytime you start warfarin to avoid that prothrombotic phase? Well, the answer is yes, but clinically this really isn't much of an issue, because for active clot disorders like someone who's got a vein thrombosis or a pulmonary embolism, we always start heparin first for its acute onset. So you would never start warfarin alone for that condition under any circumstances. The one time we sometimes start warfarin by itself and tolerate the brief prothrombotic effect is atrial fibrillation. Patients in atrial fibrillation who do not have stroke symptoms don't have an active clot, they're just at risk for a clot. So we will often start warfarin without heparin and tolerate that brief increase in the risk of clot because the overall increase is very low. Let's talk about chronic oral anticoagulation. There are several indications for when you might want a patient to take an anticoagulant every day. The most common one is atrial fibrillation, but like I said before, mechanical heart valves and prior clotting disorders are another one. And it used to be that the standard was warfarin. This had a low cost and it was a time-honored therapy, but it did have a downside, which is that you had to check the INR level in the bloodstream. Most patients had to go monthly to the lab. There are now 3 alternatives to warfarin called novel oral anticoagulants. These are the 2-factor 10A inhibitors, rivaroxaban and apixaban, and the 1 direct thrombin inhibitor, dabigatran. And the upside of these drugs is that there are no INR checks. It's the same dose for all patients. And the biggest downside is the cost. So these drugs are quite expensive compared to warfarin. Another potential downside is there are no reversal agents yet. You can reverse warfarin with vitamin K. We'll talk about that in a minute, but these drugs don't have reversals. So in theory, if a patient had a major bleeding complication, you would just have to ride out the drug. You couldn't reverse it. These drugs have only been proven effective in atrial fibrillation, so you won't see them used in other clotting disorders. For our last drug in this module, let's talk about thrombolytics. These are drugs like TPA, streptokinase, and urokinase, and they convert plasminogen to plasmin, and plasmin is a very powerful clot-busting factor in the blood. It can convert fibrin into fibrin degradation products and directly destroy clot. This is used in acute MI and acute stroke, and when these drugs first came on the scene about 20 or 30 years ago, they really represented a paradigm shift because the prior treatment for acute MI and acute stroke was bed rest and aspirin, so these really let us actively try and destroy the clot before it could cause damage. All of these drugs carry a very serious bleeding risk, including a risk of intracerebral hemorrhage, so patients need to be carefully assessed for their appropriateness for the drug before you administer it. Now let's talk about how we monitor the effects of anticoagulants, and there are really 2 drugs that we routinely monitor, and those are heparin and warfarin. So recall that there is an extrinsic pathway which is activated by adding tissue factor, and then an intrinsic pathway, and we monitor these 2 pathways with different tests. The intrinsic pathway is monitored by a blood test called the activated partial thromboplastin time, but in the hospital we just call it the PTT for simplicity. This test is done by adding plasma to a negatively charged substance, usually silica, and measuring how long it takes for a clot to form, and normal is about 30 seconds. To test the extrinsic pathway, we do a test called the prothrombin time, or PT, and we add plasma to tissue factor and we see how long it takes for a clot to form, and normal is about 10 seconds. Now, because there's variability in how this test is performed from one lab to another, we take the patient's prothrombin time and divide by a control for each lab to get an INR value. So normal would be 1 and therapeutic would be 2 to 3. And usually we don't talk about the PT itself very much. We talk instead about the INR. And for a patient, for example, with AFib, the target INR is usually 2 to 3. So the 2 regularly monitored blood tests then are PT-INR and PTT. There are 2 other rarely used blood tests that I mentioned because they come up on the boards. Those are the thrombin time and the bleeding time. PT, PTT, and thrombin time all measure fibrin formation, and the bleeding time measures platelet activity. Clinically, though, we never use the thrombin time and bleeding time. These are really just things that come up on your test sometimes. So heparin is monitored through the PTT by checking the clotting time of the intrinsic pathway, and you can remember the I in heparin is for intrinsic. And the reason for this is purely experimental. When we try to monitor the extrinsic pathway in the PT, we find that it's not very sensitive to heparin dosing. You have to be on a very high dose of heparin for the PT to be affected. On the other hand, the intrinsic pathway is more effective, and therefore that's what's monitored. Warfarin, on the other hand, is monitored by the PT-INR in the extrinsic pathway, and the reason for this is because factor 7 has the shortest half-life of all the factors affected by warfarin, so its level will fall first, and the extrinsic pathway will become abnormal first. If you wait for the intrinsic pathway to be affected, you will be waiting a long time. This is the much more sensitive pathway to monitor. What if you want to reverse the effects of this drug? Well, fresh frozen plasma is often used for this. This is plasma after removal of red cells, white cells, and platelets, and it's frozen for storage. Once you thaw it, you have to use it within 24 hours because the clotting factors degrade, but it will correct deficiencies of any clotting factor, and the PT and PTT will normalize. Vitamin K is used as an antidote for warfarin. We give it PO or IV, but we much prefer the PO form, the oral form, because the IV form has a risk of anaphylaxis. the actions we take depend on the elevation in INR. So if our goal is 2 to 3 and the patient's INR level is 3 to 5, we'll just hold warfarin and not administer any antidote. If the level's 5 to 9, we'll hold warfarin and give oral vitamin K. And if the level's over 9, that's when we'll sometimes consider IV vitamin K or administer fresh frozen plasma. And that concludes our module on antithrombotic drugs.